Okay, so good afternoon. Welcome back, all of you, to the Gyne ATP session, the Achhi Tarah Padho session of Gyne, which is especially for the FMG students. But if any NEET PG students are attending, then you are also going to benefit from it, although you have to study one level higher than this. But this is basic what you also need to know, right? So equally it can be attended by both the FMG bachas and by the NEET bachas, right? Now first I want to know that am I audible and am I visible properly to all of you? It's buffering. It's on my end, it's not showing any buffering, beta. I'm sure. Just check your internet connection. Check your internet connection. Tell me, for all of you, is it buffering? It's fine, ma'am. Yes, ma'am. अब मेरे को yes, ma'am का क्या समझना है? बफर हो रहा है कि नहीं हो रहा है? Everything is good. Acha. Shubham, in heart disease of mother, it's forceps which are preferred. Heart disease of mother में, PIH में, fetal distress में, in all of them, it is forceps which is preferred. Right? Okay. Now coming to gynae part. The PDF of this session, the blank PDF of this session is there on the SSS Telegram group, and it is there on the CTG Telegram group as well. So if anyone is wanting the blank PDF, you can download it from there. As far as the annotated PDF is concerned, once the session is over, towards the night, I am going to upload the annotated PDF. तो इसीलिए immediately messages मत करना कि मैम immediately annotated भेज दो, immediately annotated भेज दो. I will send the annotated PDF, but it will take me some time, right? So as of now, we are going to start with Gyne, and the blank PDF is there on the SSS Telegram group and on the CTG Telegram group. When we are talking about Gyne, the first important thing which you have to revise is the hormones and the menstrual cycle part of it. In your FMG exam, sometimes they ask you direct questions on the menstrual cycle, and I'm going to teach you only, I'm going to revise only that much what is required at this point of time, right? But then it is going to take some time. So coming to important points on menstrual cycle. Oogenesis begins in. So oogenesis, please remember, it begins in intrauterine life, whereas spermatogenesis begins at the time of puberty. Then fertilizable span of the ova. What is the fertilizable span of the ova? Fertilizable span of ova is 12 to 24 hours. If you have to choose between 12 to 24 hours, then it is 24 hours. What is the size of a mature follicle? Size of the mature follicle is 18 to 20 millimeters. Instead of writing mature follicles, the term Graafian follicles can also be written, right? Now, please remember there are various stages through which a follicle is going to pass so that it becomes a Graafian follicle. Pehle to understand what is a follicle. I'm sure all of you remember I have told you in class, it is a primary oocyte surrounded by follicular cells. A primary oocyte surrounded by follicular cells, and these follicular cells, they then differentiate into granulosa cells and theca cells. GC is granulosa cells and TC is theca cells. So this structure is what is called as a follicle. Now sometimes they yes, Dr. Preeti, it is going to be available even after the session is over. Till your exams are not over, it is going to be available there. Okay? Now, till the time a follicle, जब एक follicle के अंदर cavity दिखने लगती है, whenever you start seeing a cavity inside the follicle, right, then it is called, this cavity is the antral cavity, and then the follicle is called as antral follicle. So sometimes antral follicle को वो लोग mark करते हैं. Any follicle with a cavity inside is an antral follicle. And antral follicle के बाद बनता है Graafian follicle. Now, just one request to all of you, beta. When I am teaching, if you are going to ask me so many questions, my entire flow gets disrupted. right? My attention goes towards your questions. So neither I will be doing justice to answering your questions because I will be ignoring them. And in the meantime, my flow will also get broken. So I will give you enough time to ask questions to me, whether it is related to marrow, whether it is related to one touch, whether it is related to whether these sessions are enough or not. I will give you enough time to ask questions to me before I say I end the session. But it's my request that when I am teaching, right, please at that point of time don't ask me such questions. My entire flow is going to get disrupted. Okay? Okay. Now, when are the follicles maximum? Follicles are maximum in 5th month of intrauterine life. That is at 20 weeks of intrauterine life. At that time, the number of follicles is 11 to 12 million follicles. Right? So, sorry, it's 6 to 7 million follicles. 6 to 7 million follicles. Then at the time of birth, it is 1 to 2 million follicles. So that means ये जो follicles हैं, they are undergoing a programmed cell death. अपने आप से the follicles die. At puberty, the number of follicles is 4 to 5 lakh. And what do you understand by menopause? Menopause, which is now called menopause, is a condition where there are no more follicles. When there are no more follicles in the ovary, that condition is called as menopause, right? So these are all very, very important questions which they keep on asking you. Then related to menstrual cycle, they ask you questions on ovulation. What is meant by ovulation? Ovulation means when a primary oocyte changes into secondary oocyte and a follicle changes into corpus luteum. That is what is called as your ovulation. Now, all of you know that ovulation happens because of LH surge. Now, the question which they ask you is, LH surge occurs due to. LH surge occurs due to. So, LH surge occurs due to what hormone? Which hormone is responsible for LH surge? This is your PYQ. Who's going to answer that? LH surge occurs because of which hormone? Who's going to answer that? Quickly tell me. LH surge occurs because of which hormone? Your PYQ. Excellent, AG. Whoever is AG, excellent, it is estrogen. Estrogen. Right? LH surge happens due to estrogen. So, पहले estrogen की peak होगी and then LH की peak होगी. Right? Now the question which they ask you is, see, understand, if this is the place where ovulation is happening, right, they ask you what is the time gap between LH surge and ovulation. LH surge का मतलब है the time when LH begins to increase. So when LH begins to increase, वहां से लेके ovulation, what is the time gap between LH surge and ovulation? What's the time gap between LH surge and ovulation? 24, best answer is 32 to 36 hours. If 32 to 36 hours is not given, second best answer is 24 to 36 hours. Best answer 32 to 36 hours. If that is not given, then 24 to 36 hours. Right? Now, this point over here is when LH is maximum, that is LH peak. So if they ask you what is the time gap between LH peak and ovulation, what has happened to my pencil? Wait, just hold on, beta. One second, just 1 second. There is some problem, some issue with my Apple Pencil. Got it. Now tell me, what is the time gap between LH peak and ovulation? It is 10 to 12 hours. 10 to 12 hours. Third important question. What is the time gap between estrogen peak and LH peak? What is the time gap between estrogen peak and LH peak? बताओ, estrogen peak and LH peak. This, इन दोनों peaks के बीच में what is the time gap? This, what is this time gap? Who's going to, excellent, who's this? NANI, very good. It is 14 to 24 hours. Very good. The time gap between estrogen peak and LH surge is 14 to 24 hours. Okay. Now, day of ovulation. They ask you questions on day of ovulation. So, whenever we have to calculate the day of ovulation, it is 14 days prior to the next menstruation. Or if you want to calculate the day of ovulation, whatever is the length of the cycle given to you, from that you have to subtract 14 and you will get the day of ovulation. For example, if the length of the cycle given to you is 40 days, then the date of ovulation is going to be 40 minus 14, which is day 26. Right? That is how you have to calculate the day of ovulation. Right? Okay. Then, as I told you, ovulation means primary oocyte is going to get converted into secondary oocyte, and जो follicle होता है that gets converted into corpus luteum. Now the questions which they ask you on corpus luteum. Number one question is, corpus luteum in a non-pregnant female is maintained by. So in a non-pregnant female, corpus luteum is maintained by which hormone? In a non-pregnant female, corpus luteum is maintained by which hormone? Tell quickly. Jaldi batao. LH. Excellent. Excellent, Priyanshu, Anku, Mohammed. It is LH. Same function in pregnancy is done by? Same function in pregnancy is done by? एक ना कृष्णन मीनाक्षी सुंदरेशन, whatever your name is, I'm so sorry to pronounce it. Beta, I would want that once these sessions are over, in OBGY especially, you know, there are some answers which you are giving wrong. I'm not demotivating you, but you are actually trying to give the answers. That is making me happy. So, एक बार जब ये session हो जाएगा ना, please go through these sessions twice. If you go through these sessions twice, then you will not have any difficulty. ठीक? Now, corpus luteum in pregnancy, all of you have said that it is maintained by HCG. Lifespan of corpus luteum in a non-pregnant female. Lifespan of corpus luteum in a non-pregnant female. What is the lifespan of corpus luteum in a non-pregnant female? Ranjan Kumar, 10 to 12 days. ठीक है? Anyone else? 12 to 14 days. Priyanshu, very good. 12 to 14 days. Excellent. Hormone which prevents luteolysis. Which hormone prevents luteolysis? So corpus luteum is about to die. ऐसा कौन सा hormone आता है जो corpus luteum को it prevents corpus luteum from dying? Which is that hormone? Which is that hormone which prevents corpus luteum from dying? 12 to 14, 12 to 16, both are correct answers. It's okay. Now tell me which hormone prevents corpus luteum from dying. So proud of all of you. It is HCG. Corpus luteum is about to die, but अगर female pregnant होती है, then HCG prevents corpus luteum from dying. When is the maximum size and activity of corpus luteum seen on? This same question can be asked is that during a menstrual cycle, when are the levels of progesterone maximum? Question I, when are the levels of progesterone maximum? Yeah, question I, when is the size and activity of corpus luteum maximum? What is your answer going to be? It is going to be day 22 of the cycle. Day 22 of the cycle. Beta, this session is also for NEET PG, and I told you I am going to do an image based session for NEET PG. I will definitely do that, right? That is 8 days after ovulation. So please understand, this question can be asked in 4 formats. They can ask you that during a menstrual cycle, when is the size of corpus luteum maximum or maximum or activity of corpus luteum maximum? Answer is 8 days after ovulation, that is day 22 of the cycle. Same question can be asked, when are the levels of progesterone maximum? Now, when the levels of progesterone are maximum, progesterone has a negative feedback on LH and FSH. So, same question can be asked that when are minimum levels of LH and FSH seen in a cycle? Then also your answer is going to remain the same, that it is seen on day 22 of the cycle. सेम क्वेश्चन को पूछा जा सकता है एक और तरीके से, एंड व्हाट इज दैट? Whenever in an infertile couple, I want to know whether the female is ovulating or not, I have to check कि progesterone present है कि नहीं है. So all the tests for ovulation, they are done on day 22 of the cycle. Same question can be asked in 4 different formats. So as I was telling you, all the tests for ovulation, they are done on day 22. Let us talk about what are the tests for ovulation. Number 1, what are the hints in the history of the patient which tell you that your patient is ovulating? Number 1, if you ask your patient and she says that she's having regular cycles, so these are all indirect evidences. Whenever they ask you a question, what is the indirect evidence of ovulation? So history based evidence is indirect evidence of ovulation. And वो क्या होगा? कोई भी female अगर कभी भी हमें कहेगी ना कि उसकी cycles regular हैं, so that means she is ovulating. Why? Because जो anovulatory cycles होती हैं, remember, anovulatory cycles, they are irregular. ये characteristic होती है anovulatory cycles की, they are always irregular. Number 2, anovulatory cycles are painless, right? And number 3, anovulatory cycles में there is going to be estrogen breakthrough bleeding. They are due to estrogen breakthrough bleeding. Right? Progesterone तो होता ही नहीं है, तो progesterone withdrawal is not responsible for them. जो normally when a female is menstruating, normal menstruation is because of progesterone withdrawal. And जब progesterone withdraw करता है, remember, normal menstruation is due to progesterone withdrawal. And जब progesterone withdrawal करता है, there is vasospasm. Why? Because we all know progesterone is a smooth muscle relaxant. तो जब भी progesterone withdrawal करेगा, vasoconstriction होगा, vasospasm होगा, जिसकी वजह से PGF2 alpha release होता है. And it is this PGF2 alpha which leads to pain. That is dysmenorrhea. So this means कि कभी भी अगर एक young girl मेरे पास आती है and she is saying that she is having dysmenorrhea, indirectly I come to know, oh, her cycles are ovulatory, right? But इसका मतलब कभी भी ये नहीं होता बेटा कि अगर किसी फीमेल को पेन नहीं फील हो रहा है, so always she is having anovulatory cycles. हर फीमेल का एक थ्रेशोल्ड होता है to feel the pain, right? So pain हो रहा है, that is an evidence of ovulation. Pain नहीं हो रहा is not an evidence of anovulation. I hope this point is clear to all of you. कितनी ऐसी females होती हैं जिनको pain feel नहीं होता? That doesn't mean all of them are having anovulatory cycles. But yes, अगर pain हो रहा है, then definitely that means कि she is having ovulatory cycles. Clear to all of you? Yes? So, indirect evidence of ovulation is if a female is having regular cycles or if there is Michel-Merz syndrome. What is Michel-Merz syndrome? Again, a very important question. Michel-Merz syndrome means that there is pain due to ovulation. Some females have pain due to ovulation. My voice is breaking. Is there some unstable internet connection? I don't know. I am sorry, but I can't help it at this point of time. So, in Michel-Mer's syndrome, typically a female will complain of mid-cycle pain. Mid-cycle pain, right? Whenever a female has dysmenorrhea or premenstrual syndrome, all these are indirect evidence of ovulation, right? As I told you, anovulatory cycles are due to estrogen breakthrough and they are not because of progesterone withdrawal. They are painless, irregular and they are associated with heavy bleeding. ठीक है? Now coming to the tests of for ovulation, ये जो test I am going to tell you, which are the tests for ovulation, they tell you in a retrospective manner कि female ने ovulate किया कि नहीं किया. And all these tests are done on day 22 of the cycle. First test is basal body temperature test. Please remember, progesterone increases the basal body temperature. Right? That is why agar aap any female around the mid cycle, if her basal body temperature increases, it means that she is ovulating. If her basal body temperature doesn't increase, that means she's having anovulatory cycles. Number one. Number two test is cervical mucus study. Menon Sajid. This is for both of you. Both FMGs and PGs can attend this session. Coming to cervical mucus study. Please remember, under the effect of estrogen, ये बहुत बार क्वेश्चन पूछा गया है कि सर्वाइकल म्यूकस की कैरेक्टरिस्टिक क्या होती है अंडर द इफेक्ट ऑफ ईस्ट्रोजन. अंडर द इफेक्ट ऑफ ईस्ट्रोजन, सर्वाइकल म्यूकस इज प्रोफ्यूज, watery, elastic and it can be stretched. This is called as spin barkite. Right? ये PG में क्वेश्चन पूछा गया है, but this time I don't know why I feel कि इसमें से कुछ भी can be asked in FMG, and that is why all the DBMCI students you are going to write this point if I have not made you write it earlier. Write this point that cervical mucus will be profuse, watery, elastic and it can be stretched. That is what is called as spin barkite. Under microscope, you get a fern-like appearance. Ferning appears on day 7 of the cycle. Right? Under the effect of progesterone, cervical mucus is thick, scanty, viscous. It cannot be stretched and the ferning disappears by day 17 of the cycle or day 18 of the cycle. Right? So ferning is going to disappear. Clear? Copied all of you? जिन के पास ये point नहीं लिखा था, please write it. Under the effect of estrogen, cervical mucus thin होता है. देखो, फर्स्ट हाफ ऑफ द साइकिल में एवरीथिंग इज हैपनिंग इन सच अ मैनर कि स्पर्म जो है वो बहुत इजीली ओवा के पास पहुंच जाए. दैट इज व्हाई you get that cervical mucus is profuse, watery, elastic and it can be stretched. Second half of the cycle में everything is happening in such a manner कि by chance fertilization हो गया है तो अब कोई और sperm ना पहुंचे. So that is why cervical mucus becomes thick, scanty, viscous. ठीक है? Okay. Now, that is so if you do a cervical mucus study, you can come to know whether a female has ovulated or not. Right? Ferning appears on day 7 or day 8 of the cycle and it disappears by day 17 or 18 of the cycle. It's one and the same thing. Right? You can, PGs, I have made you write day 8, you continue with day 8 because William says day 8. FMGs, you continue with day 7, hardly matters because Datta says day 7. ठीक है? Okay. Now, vaginal epithelial study. Vaginal epithelial study may remember under the effect of estrogen, the cells which you are going to get will be superficial cells. and under the effect of progesterone, the cells which you get are intermediate cells. So again, vaginal epithelial study can help me knowing whether a female has ovulated or not. Now my next question to you is that from where are you going to take a sample? For vaginal epithelial study, from where are you going to take a sample? Sample कौन सी wall of vagina से लोगे? Sample has to be taken from lateral wall of vagina. ठीक है? Then you can do endometrial biopsy. Endometrial biopsy can also tell you, right, that whether a female has ovulated or not. Under the effect of estrogen, the glands which you get are very simple tubular glands. Simple tubular glands. Whereas under the effect of progesterone, the glands which you get are coiled glands, and these coiled glands are called as corkscrew appearance of the glands. Corkscrew appearance of glands, or this is also called as sawtooth appearance of gland. Corkscrew appearance of gland or sawtooth appearance of gland. Then serum progesterone levels. You can check the serum progesterone levels on day 22. Please remember, endometrial biopsy is not done for this purpose. I could have done this, but it is not done for this purpose. Number 1. Number 2, endometrial biopsy का indication these days is for diagnosis of genital TB. For diagnosing genital TB, I am going to do endometrial biopsy, right? Okay. Then you can check serum progesterone levels. This is the best test for ovulation. If question comes, what is the best or the easiest test to know whether a female is ovulating or not? It is serum progesterone levels. Easy है ना? Blood को निकाला and progesterone के levels check कर लिए. कब check करोगे? Day 22 of the cycle. अगर progesterone levels high हैं, that means she has ovulated. अगर progesterone levels low हैं, that means she has not ovulated. Very very simple test, right? But अभी तक हमने जितने भी टेस्ट किए, all these tests which we have done till now, all of them are the tests which are in a retrospective manner, telling you that a female has ovulated or not. Suppose I want to predict ovulation. I want to tell the time of ovulation in my patient. Are there any tests which can help me in telling my patient that this time you are going to ovulate or this day you are going to ovulate? So, tests which can predict ovulation. There are two tests which can predict ovulation. What are those two tests? Number 1, what is that test? Anyone can tell me? Two tests which can predict ovulation. कौन बताएगा? Let me see who's going to answer. कई बार ना मेरा एक मन करता है कि मैं एक चैलेंज रखूं DBMCI वर्सेस मैरो स्टूडेंट्स की. लेट मी सी कि जो मेरे को फेस टू फेस में सुनते हैं वो ज़्यादा अच्छे से आंसर करेंगे या जो मुझे ऐप में सुन रहे होते हैं वो ज़्यादा अच्छे से आंसर करेंगे. यूरिनरी LH सर्च, एक्सेलेंट. urinary LH surge, right? This is urinary LH kit होती है, जैसे urine pregnancy kit होती है, वैसे we have urinary LH surge, right? तो what a female has to do is she has to take her urine and she has to put it in this kit. And if you get two lines, that means urine में LH surge हो गया है. And अगर urine में LH surge हो गया है, तो उसके बाद ovulation will happen after 24 hours. ब्लड में LH सर्ज हुआ तो ओव्यूलेशन विल हैपन आफ्टर 32 to 36 hours. यूरिन में LH सर्ज जब होता है देन ovulation is going to happen after 24 hours. Right? Second point. Second test is follicular monitoring. Follicular monitoring. Now, follicular monitoring is a special type of TVS in which you are going to study only the follicles. Right? Now, this TVS is done from day 10 onwards and you have to do it on alternate days and you have to check the size of the follicle. Every day you will see that the size of the follicles is increasing. Right? Every day you see that the size of the follicle increases by 1 to 2 millimeters per day. Ultimately, the size is going to become 18 to 20 millimeters bolo ya more than 17 bolo. That's one and the same thing, right? So it becomes 18 to 20 millimeters per day. And uske baad achanak se the size of the follicle decreases, right? That is going to tell you that she has ovulated. There will be fluid in pouch of Douglas and there is going to be triple layered endometrium. So these are the signs which tell you that ovulation has happened, right? Why am I getting fluid in pouch of Douglas? Because I told you कि antral cavity में fluid होता है. So once the follicle is going to rupture, that fluid in antral cavity is going to come into the pouch of Douglas. So these are signs of ovulation. Coming to management of an ovulation. So once I know whether my patient is not ovulating, now what am I going to do? Please remember, if they ask you the most easily treatable form of infertility. Most easily treatable form of infertility. Nani, I'll just now tell you something. Ruk jana. Abhi you are right, but I'll come to your point also. Most easily treatable form of infertility. What is that? That is an ovulation. An ovulation में simply you have to give a drug. छोटी सी गोली देनी है. Small tiny little drug you have to give. Tablet and your patient's infertility is treated. Right? Nishant, size of the dominant follicle is 18 to 20 millimeters. Right? Now, Nani, your point. Beta, triple layered endometrium is characteristic of late proliferative phase and it is going to stay there till the time of ovulation. So ovulation ke time par bhi you are going to get a triple layered endometrium. As I have told all the NEET PG students in my marrow lectures and in DBMCI face-to-face class, that whenever they give you a triple layered endometrium ka image on ultrasound and they ask you this is characteristic of, the best answer is late proliferative phase. But if that is not given, second best answer is ovulatory phase. Right? Okay. Now, coming to FMGs, forget about it. Bas keval itta yaad rakho. You don't have to listen to what just now I said. Theek? Coming to drug of choice for an ovulation. Simple question drug of choice for an ovulation, it is clomiphene citrate. Drug of choice for an ovulation due to PCOS. If this question comes, then you have to mark the answer as letrozole, followed by clomiphene citrate, right? Then, that is your for an ovulation, treatment of an ovulation. Now, another cause of infertility in a female which is related to ovary is premature menopause. Premature menopause is also called as primary ovarian insufficiency. That's the new name for premature menopause. POI. Right? Now question aayega, what are the tests which tell you that there is decreased ovarian reserve? What do you understand by the term decreased ovarian reserve? Decreased ovarian reserve means that you have to tell whether the follicles in the ovary are decreased or not, right? Now, before I tell you what are the tests which are done to know whether the follicles are adequate in the ovary or follicles have decreased, as I told you, every month the number of follicles is decreasing. So, has it decreased so much that now a patient has become infertile? That is what is meant by the tests for ovarian reserve. Before that, a very important concept you have to remember, and that is FSH acts on granulosa cells in female, and from granulosa cells is released inhibin B. From granulosa cells is released estrogen, and from the granulosa cells of the antral follicle and the granulosa cells of preantral follicle, anti-Mullerian hormone is released. 3 hormones are released by granulosa cells: inhibin B, estrogen and anti-Mullerian hormone. Anti-Mullerian hormone किसके granulosa cell से निकलता है? Antral follicle and preantral follicle के granulosa cells से निकलता है. I'll write this properly, otherwise you will not understand it. Just let me write it properly. Antral follicle and preantral follicle. Right? So the granulosa cells of antral follicle and preantral follicle, they release anti-Mullerian hormone. Inhibin B and estrogen, they have a negative feedback on FSH. Right? Another important point is LH acts on theca cells, and from theca cells in females, from puberty onwards, androgens are produced. Right? So now understand. In a patient, in a female in whom there are less follicles, inhibin B levels will be decreased, estrogen levels will be decreased, anti-Mullerian hormone levels will be decreased, FSH levels would be increased, because the negative feedback on FSH would be gone. Right? So FSH levels would be high. So the tests which we do for ovarian reserve, the time for doing these tests is day 2 or day 3 of the cycle. You can check inhibin levels will be decreased. You can check FSH levels would be increased. How much increased? Please remember, कुछ की ही values याद रखनी होती हैं, बस remember FSH, normal FSH values are 1 to 10 international units. If FSH values, they become more than equal to 40 to 45 international units, that is diagnostic of menopause या premature menopause. They are diagnostic of menopause or premature menopause. What is antral follicle count? Antral follicle count का मतलब है कि I am counting the number of follicles on ultrasound. So this is on ultrasound, you have to count the number of follicles. Again, on counting the number of follicles, they would be decreased. So these are the tests for ovarian reserve. Number 1, inhibin levels. Number 2, FSH levels. Number 3, antral follicle count. ये वो टेस्ट हैं which have to be done on day 2 or day 3 of the cycle. There is one test which can be done on any day of the cycle, that is anti-Mullerian hormone levels. Because anti-Mullerian hormone can be done on any day of the cycle, that is why it is the best test for ovarian reserve. Values of anti-Mullerian hormone, remember, it is between 1 to 3. I mean, it's 1-3. Don't say 1, 2, 3. 1-3. If it is less than 1, that indicates POI, that is menopause, या premature menopause. And if it is more than 3, right? If it is more than 3, it indicates PCOS. Please remember, in PCOS, there are many follicles. बहुत सारे follicles है ना, polycystic ovarian syndrome. And actually they are not cysts. क्या होते हैं? बहुत सारे follicles होते हैं. When there are going to be many follicles, they will release a lot of AMH. So AMH levels are high in PCOS. AMH levels are less in premature menopause या menopause. ठीक है? Okay. Now, anti-Mullerian hormone, this is what I have written over here also. It is a glycoprotein which is produced by the granulosa cells of preantral and antral follicles. Its normal values are 1 to 3. If it is less than 1, that means it's a poor ovarian reserve. If it is high, it is seen in PCOS. Clear to all of you? Show me a thumbs up if you've understood till here. Now, one of the tests which is outdated for ovarian reserve is clomiphene citrate challenge test. So just the name कि this is an outdated test for ovarian reserve. अब question कैसे आएगा? Question आएगा all of the following are tests for decreased ovarian reserve or for ovarian reserve except. उस except का आंसर क्या होगा? They are going to give you a list of tests. All of the following tests are done for ovarian reserve except. उस एक्सेप्ट का आंसर होता है सीरम प्रोजेस्टेरॉन लेवल्स. प्लीज रिमेंबर, अभी हमने किया सीरम प्रोजेस्टेरॉन लेवल्स. इट इज अ टेस्ट फॉर एन ओव्यूलेशन. इट इज नॉट अ टेस्ट फॉर ओवेरियन रिजर्व. कैसे वो कंफ्यूज करेंगे? दे आर गोइंग टू कंफ्यूज यू. All of the following tests are done for ovarian reserve except option A inhibin, option B FSH, option C progesterone, option D AMH. And अब आप confuse हो जाओगे. So remember, progesterone is not a test for ovarian reserve. Serum progesterone is a test for an ovulation. अब अगर serum progesterone नहीं दिया है, right, on most of the time serum progesterone options में दिया होगा. But if serum progesterone is not given in your answers, then look for estrogen. Estrogen को generally हम test नहीं करते हैं in a menopausal female. It would be decreased, but that is not a very good test, right? Question is this, which has come in your PYQs. Which of the following best measures ovarian reserve? Which of the following best measures ovarian reserve? Tell me. As I told you, the best test is anti-Mullerian hormone. Why it's the best? Because it can be done on any day. My next question to you is, what is the management of infertility due to decreased ovarian reserve? What is the management of infertility due to decreased ovarian reserve? अब किसी फीमेल में follicles नहीं है, how can I make her conceive? What can I do? I can take donor X plus I can go for IVF. So I will do IVF with the help of donor X. Excellent smart surgeon, right? Coming to dysmenorrhea. Dysmenorrhea पे questions are asked in FMGE as well as NEET PG. Now there is something which is primary dysmenorrhea. Why is primary dysmenorrhea happening? Primary dysmenorrhea is happening because of the release of PGF2 alpha. Primary dysmenorrhea में you are going to get a young girl, and young girl is going to say, she is going to complain of pain, right? And she is going to say कि leave aside the 6 months, 1 year period when I started my menarche. उसके बाद से ever since my menarche I am having pain. So she complains of pain since menarche. This pain, as I told you, there is no pathology responsible for this pain. ये जो primary dysmenorrhea होता है, ये होता है because of PGF2 alpha का release. There is no problem in the female. There is no pathology which is causing this pain, right? And that is why we will have a young girl who's going to say कि कुछ time तक उसको pain नहीं हुआ था, because at that time she would be having anovulatory cycles. So 6 months, 1 year तक उसको pain नहीं हुआ. After that she is having a lot of pain. This pain begins with menses or just before the periods, and it is going to decrease within 72 hours of the periods. ये जो pain होगा, ये centralized pain होगा and suprapubic pain होगा. This pain decreases after physical activity, after marriage and childbirth, right? And इस pain को relieve करने के लिए we can tell her to use NSAIDs or we can advise her to use OCPs. Why we advise her to use OCPs? To make the cycles anovulatory, right? So dysmenorrhea का drug of choice is OCPs. Clear to all of you? Dysmenorrhea के लिए it is OCPs. बेटा मेफेनेमिक एसिड इज नॉट नाउ द ड्रग ऑफ चॉइस. एनसेड्स होते हैं बट ड्रग ऑफ चॉइस, एनसेड्स कैन बी यूज्ड बट ड्रग ऑफ चॉइस इज ओसीपीज. ठीक है. नाउ कमिंग टू सेकेंडरी डिस्मेनोरिया. सेकेंडरी डिस्मेनोरिया इज कंजेस्टिव डिस्मेनोरिया. सेकेंडरी डिस्मेनोरिया, just hold on one second. Sir, I am in a live session. Can I give you a call after that? Yes. Right. So, coming to secondary dysmenorrhea. Secondary dysmenorrhea is congestive dysmenorrhea. Secondary dysmenorrhea, there has to be some reason for the pain. Right, that is some pelvic pathology which is causing pain. That is secondary dysmenorrhea, and most of the times it is endometriosis. Most common cause of secondary dysmenorrhea is endometriosis. Ab in case of secondary dysmenorrhea, you will have a reproductive age female, right? A reproductive age female who is going to say that all of a sudden she has started having pain. Earlier there was no pain. But now she is having pain. Right? 30-35 years की female, 40 years की female आएगी ये complain लेके. Right? That is secondary dysmenorrhea. Secondary dysmenorrhea में pain occurs much before the menses and it remains there even after the onset of period. So please understand, secondary dysmenorrhea में more than half of the cycle goes in pain. Right? There is nothing like that कि within 72 hours of the onset of periods female का pain relieve हो जाएगा. Nothing like that happens. Right? Pain is localized and pain progressively increases. Very, very important point. And per vaginal examination में suppose your question says कि कोई adnexal mass feel हो रहा है या कोई adnexal tenderness feel हो रही है, anything, you know, any abnormal per vaginal finding if they give you, that means it is secondary dysmenorrhea. Whether they say uterine tenderness, कुछ भी बोले, any abnormal finding if you are getting on per vaginal examination, that means it is secondary dysmenorrhea. In secondary dysmenorrhea, you have to treat the cause. Clear to all of you? My next question to you over here is related to causes of, अच्छा चलो, this I'll ask you when I'm doing endometriosis and fibroid. अभी आगे जब उसका revision करेंगे, then I'll ask you that. Okay. Now tell me, coming to puberty. Let's talk about puberty. Tell me, what is the normal age of puberty in a female? Normal age of puberty in females? What's the normal age of puberty in females? जल्दी बताओ. 13 years. That's the normal age of puberty. Priyanshu, very good. Shahrukh, bad. Beta, Jaya, concept sab clear karo. Normal age is 10.5 years. 10.5 years. That's the normal age of puberty in females. जो आप लोग बोल रहे हो ना 13 years, that is delayed puberty. Normal age of puberty is 10.5 years. And when puberty happens at 10.5 years, menarche कब होगी? Menarche होगी after 2 years. That is 12.5 years. Right? Okay. Now, coming to precocious puberty. When do you say, acha, what is the normal age of puberty in males? 11.5 years. Take. Now, what is precocious puberty? Precocious puberty is when in females puberty happens at less than 8 years. That is precocious puberty. I will be providing the annotated PDF, don't worry. What is precocious menstruation? Precocious menstruation is when menstruation happens at less than 10 years, right? When precocious puberty, when menarche happens at less than 10 years, that is precocious menstruation. Please remember, precocious puberty is more common in females than in males. Most common cause of precocious puberty is idiopathic, but 10% cases में 10% cases of precocious puberty are due to brain tumors. They are due to brain tumors like hematoma. That is why whenever you have a patient of precocious puberty, you should rule out brain tumors. And the investigation which you have to do is MRI. MRI, it has to be done in all patients of precocious puberty, right? What is the drug of choice for precocious puberty? Drug of choice for precocious puberty is continuous GnRH. Continuous GnRH. That's the drug of choice for precocious puberty. Now, there is one syndrome which I want all of you to know, right? So, what is that syndrome which leads to precocious puberty? McCune-Albright syndrome. McCune-Albright syndrome. McCune-Albright syndrome में what do you get? In McCune-Albright syndrome, you get precocious puberty, you get cafe au lait spot on skins. Skin में you get cafe au lait spots and bone lesions. What are those bone lesions? Polyostotic lesions. Polyostotic bone lesions. Right? So this is McCune-Albright syndrome. Clear to all of you? Yes? Then, coming to delayed puberty. Delayed puberty, if in females puberty has not happened till 13 years. That is what is fibrous dysplasias बोल दो या you call it as polyostotic fibrous dysplasias. Perfect, perfect Prachi, perfect Suruchi. Right. What is the most common cause? Acha, please remember, delayed puberty is more common in boys than in girls. So it's more common in males than in females. Most common cause of delayed puberty is constitutional delay. Constitutional delay. And what is the drug of choice for delayed puberty? Drug of choice for delayed puberty is pulsatile GnRH. Pulsatile GnRH. Always remember, whenever you are giving GnRH in a pulsatile manner, it is going to increase estrogen. Whenever you give GnRH in a continuous manner, it is going to decrease estrogen. Right? Then, what is the sequence of puberty in females? What is the sequence of puberty? So, first sign of puberty in females is growth spurt. I don't want any of you to tell me in the chat box कि pediatrics में क्या पढ़ाया है. Hardly matters जो भी पढ़ाया हो. In this case, I am a little dominant that you are going to write what I am telling you. You are going to answer what I am telling you. Growth spurt. Don't tell me कि pediatrics में थिलारकी पढ़ाया है. पढ़ाया होगा, but you are going to mark the answer as growth spurt. Because Williams is saying growth spurt. Right? So, the first sign of puberty is growth spurt. The first visible sign or the first specific sign or the most specific sign is thilarchy. Thilarchy. Right? Vijay, that is what I was telling you. Chat box में ये मत लिखना पीडिया में क्या बताया है. Mark what I am telling you. Write what I am telling you. ठीक? I mean, not because I am telling you, because Williams is saying that. The latest edition of Williams says that. Then after thelarchy, what will be the sign? After thelarchy, that thelarchy is breast budding. Breast budding. Then you are going to have pubarchy. What is pubarchy? Appearance of pubic hair. Appearance of pubic hair, right? Then you are going to have peak height velocity. And then there is going to be menarche, right? What is the first sign of puberty in males? It's testicular enlargement. Chalo. Now coming to Tanner staging. Tanner stage 1 or 2 means that it is underdeveloped breast. Underdeveloped or less developed breast. Less developed or underdeveloped breast and pubic hair. Whenever your question says Tanner stage 4 or 5, what does that mean? That means well developed breast. Well developed breast, yeah, well developed pubic hair. You don't need to know the full staging, you just have to remember this. Tanner stage 1 or 2 is underdeveloped or less developed breast and pubic hair, and Tanner stage 4 or 5 means well developed, right? Now, if your question says secondary sexual characteristic are present, whenever your question says secondary sexual characteristic present, that means breast is present, right? And that means estrogen is normal, because the hormone which is responsible for breast development is estrogen, right? Whenever your question says secondary sexual characteristic absent, that means breast absent, and that means estrogen is decreased, right? So breast absent का मतलब है कि estrogen decreased, breast present का मतलब है estrogen levels are normal. Now, if your question says pubic hair and axillary hair are normal, that means androgens are normal. Why? Because the hormone responsible for pubic hair and axillary hair in a female is also androgen, right? So whether it is a male or whether it is a female, for pubic hair and axillary hair development, which hormone is required? Androgen is required. Now, whenever your question says that there is a female who has come to you with primary amenorrhea with bilateral inguinal hernia, जहां पर भी ये देखो term bilateral inguinal hernia. Actually, it is not bilateral inguinal hernia. Actually, they are undescended testes. These are small hints which you have to remember, because I know all of you are so confused whenever you get questions related to primary or secondary amenorrhea. So these are the hints which are going to tell you to how you are going to come to a diagnosis. So whenever your question is saying that there is primary amenorrhea with bilateral inguinal hernia, that means they are undescended testes, and that means karyotype is 46XY. अब 46XY इंडिविजुअल जिसके फीमेल हो, 46XY जो कि आपको फीमेल की तरह दिख रहा हो, राइट? There can be only two situations. One is androgen insensitivity syndrome, and the other one is Swier's syndrome. केवल दो situation होंगी. As far as FMG exams are concerned, there will be only two situations जहां पे a question will come that a female is coming to you with primary amenorrhea with bilateral inguinal hernia. So either your answer has to be androgen insensitivity syndrome or your answer has to be Swier's syndrome. अब कैसे चूज करोगे अपना आंसर? Androgen insensitivity syndrome के question में they will say breast is well developed. Swier's syndrome में breast is not developed. Second important thing, Androgen insensitivity में uterus is absent. Swires में uterus present. And now your questions are super easy for you to solve. The moment your question says bilateral inguinal hernia, immediately you have to think about only two things. Either you are dealing with androgen insensitivity syndrome or you are dealing with Swires syndrome. Androgen insensitivity syndrome के question में they are going to say breast is well developed, uterus absent. Swires में breast not developed, uterus present. Clear to all of you? Yes? Now, some other concepts, because now what is happening these days, they are asking you questions related to hormones. They will ask you primary amenorrhea, secondary amenorrhea, LH levels essay, FSH levels essay. So you have to have a clear understanding of the hormone, and that is why quickly we are going to revise hormones. In females, hypothalamus say what is released? Hypothalamus releases GnRH. This is going to be released at puberty, right? And this GnRH is going to be released in a pulsatile manner. Now this GnRH is going to act on anterior pituitary, and from anterior pituitary FSH and LH will be released. Now FSH is going to act on the ovary, and from the granulosa cells it is going to release inhibin and it is going to release estrogen. LH is going to act on the ovary. It will bring about ovulation, and because it brings about ovulation, progesterone is formed. This is what is happening in females. Please remember, estrogen always estrogen will have a negative feedback on FSH. Always, right? Estrogen usually has a negative feedback on LH, but only in one condition. There is one exception, and that exception is when estrogen levels are more than 200 picograms. ये ना ऐसे ही याद करना है. When estrogen levels are more than 200 picograms for 48 hours. Balveer, this class is useful for Norset or not? Abhi Norset ke liye nahi. Don't do it for Norset just now. Right? Norset ke liye I'll take a different class. This is a Gyne class and this is too much of Gyne for Norset. Norset mein itni Gyne nahi aati. Estrogen levels more than equal to 200 picograms for 48 hours. It leads to LH surge. That is the time when it is going to increase LH. Otherwise, normally estrogen has a negative feedback on both LH and FSH. Only in one condition estrogen has a positive feedback on LH, and that is when the values of estrogen are more than 200 picograms for 48 hours, right? As far as progesterone is concerned, progesterone in low concentration has a positive feedback on LH and FSH. In high concentrations, it has a negative feedback on LH and FSH, right? Coming to prolactin, please remember, ये बहुत important है. Prolactin has a negative feedback on GnRH. This is the reason why during lactation there is amenorrhea. This is the reason why if there is a prolactin secreting tumor, it is going to cause amenorrhea. Because it is going to decrease GnRH. GnRH decrease होगा तो automatically LH decrease होगा, automatically FSH decrease होगा, तो neither there is going to be estrogen nor progesterone. So obviously female will not ovulate. Clear to all of you? Yes? Now coming to males. In males, Hypothalamus will again, जैसे females में hypothalamus releases GnRH at the time of puberty, in males also hypothalamus will release GnRH at the time of puberty, which is going to act on pituitary. From pituitary, FSH and LH would be released, right? Ab FSH is going to act on Sertoli cells. So in the testes, we have two types of cells, Sertoli cells and Leydig cells. Sertoli cells are the ones which release inhibin. Leydig cells under the effect of LH. LH acts on Leydig cells and it produces testosterone. Right? Now, testosterone का क्या effect होता है LH FSH पे? Inhibin always has a negative feedback on FSH. Testosterone overall, please remember, testosterone always has a negative feedback on both LH and FSH. Right? Testosterone will have a negative feedback on both LH and FSH. Now comes a very, very important question. What is the first stimulus for the testes to release testosterone in intrauterine life? Please remember, ovaries तो ना silent होती है intrauterine life में. Ovaries never form any hormone in intrauterine life. But testes are active in intrauterine life also. So they ask you, which is that first stimulus for the testes to release testosterone in intrauterine life? Nirbhay Anuj, very, very good. Don't say it is LH. LH is not the first stimulus. LH act करता है Leydig cells पे to release testosterone, but it is not the first stimulus. First stimulus always is HCG. That is why we say HCG and LH are functionally the same hormone, because both of them have same functions. Right? Clear to all of you? Any confusion still here? Any confusions? No? Quickly in the comment section tell me, then I am going to go to GnRH and then we are going to proceed with primary amenorrhea. And how you are going to approach questions related to primary amenorrhea. No confusions, Shahrukh? Thank you for confirming. Baki, just show me your thumbs up so that I come to know that there are no confusions. Great. Chalo. Now, let us talk about GnRH. This GnRH which I am telling you is a synthetic GnRH which we prepare in the industries, right? So, ये जो GnRH है, जो synthetic GnRH है, this you can give in a pulsatile manner. This is GnRH analog. Please remember, GnRH analogs, when you are giving in a pulsatile manner, they will increase LH, they will increase FSH, and they will increase estrogen. So when do you use pulsatile GnRH? Whenever levels of estrogen are less, I can give GnRH in a pulsatile manner. So it is used for management of delayed puberty and for management of Kallmann syndrome. What is Kallmann syndrome? Kallmann syndrome is a condition where there is hypothalamic failure. There is hypothalamic failure. There is decreased GnRH. So common sense tells me, if there is decreased GnRH, so obviously I can give GnRH in a pulsatile manner, right? Okay, ma'am, which subunit of HCG is similar to LH? Remember, it is the beta subunit which is the specific subunit. Alpha subunit of HCG is similar to LH, FSH and TSH, right? Now, coming to continuous GnRH. Whenever the same GnRH, when you are going to give it in a continuous manner, it is going to decrease. One second. it is going to decrease. Oh, yeah, it will decrease LH, it will decrease FSH, and it will decrease estrogen. Not only it is going to decrease estrogen, because LH acts on the theca cells to release androgens, so it will also decrease androgen production by the ovary. Whatever is being produced by the ovary will decrease, and that is why continuous GnRH is used in the management of precocious puberty. Continuous GnRH is used for managing hirsutism, because in hirsutism androgen levels are high. The moment androgen levels decrease, then your hirsutism is treated. And it is used for management of fibroid and endometriosis. Why for the management of fibroid and endometriosis? Because both of them are hyperestrogenic conditions. Both of them are hyperestrogenic conditions. In both of them, estrogen levels are high. So the moment I decrease estrogen levels, they will become normal, whether it is endometriosis, whether it is fibroid. Iske alawa, you can use this in males for management of prostate cancer. Right? For the management of prostate cancer also you can use continuous GnRH. Clear to all of you? Now, coming to primary amenorrhea. इसकी ना definition से ही कितने सारे questions आते हैं. Dr. Kunj Prajapati, I am not saying कि hirsutism का drug of choice is GnRH. I am saying that one drug which can be used to manage hirsutism is GnRH, continuous GnRH. क्यों? क्योंकि जब आप continuous GnRH दोगे, the levels of LH will decrease, and when the levels of LH will decrease, it will not stimulate the theca cells to release androgens. So automatically hirsutism treat हो जाएगा. अभी थोड़ा सा patience रखो. I will also talk to you about the drug of choice for hirsutism. अभी आएगा. I will clear all your doubts. Coming to primary amenorrhea. Now, definition of primary amenorrhea se many questions are asked. Please remember, primary amenorrhea means if a female has not experienced menarche by 15 years of age, if there is breast present hai and she has not experienced menarche by 15 years. Breast absent hai and she has not experienced menarche by 13 years. So there are two definitions. One is if breast is present and if she is not experienced menarche by 15 years, then we call it as primary amenorrhea. Or if breast is absent and if she has not experienced menarche by 13 years, then that is primary amenorrhea. Second definition. Just now I was telling you that whenever a female has breast budding, that is whenever there is pubarche, that is puberty, and thilarche and menarche mein there is a difference of 2 years. Whenever a female is going to have onset of puberty, uske 2 years ke baad she is going to have menstruation. But suppose a female has developed breast and 3 years have passed and till now she has not had menarche, then also that is primary amenorrhea. So once breast appears, within 2 years she should be having menarche. Now I am saying 3 years have passed. Breast aa gaya, breast development ho gaya, but the patient did not have any menarche. That is also primary amenorrhea. Both these definitions are very, very important, right? What is secondary amenorrhea? Secondary amenorrhea means a female was menstruating normally and all of a sudden now for past 3 months she is not having menstruation. That is secondary amenorrhea. Or overall in a year a female should have 12 cycles. Now if she is having less than 9 cycles, then also that should be investigated because that comes under oligomenorrhea. right? That's not normal. Having less than 9 cycles in a year is not normal, and that again should be investigated. Clear to all of you? So all these definitions you have to remember. ठीक है? अब questions कैसे answer करोगे? I know this is again a pain point for all of you, that how are you going to answer questions related to primary amenorrhea. So I'm going to make it again very easy for you. I'm going to make you write in a tabulated form that question में ये आएगा तो ये answer होगा. Right? So we are going to learn it like maths multiplication tables. कि ये अगर क्वेश्चन में दिया है तो my answer has to be this. If you've understood what I taught you in class, very good. If you are a Marrow subscriber, DBMCI student, I teach all this in class. So you know the concept behind it. But if you are not my student, then again, whether you are my student or not, इस table को memorize कर लेना and all your answers will be here. Whenever your question says that there is primary amenorrhea and your question says that there is cyclical pain in abdomen, cyclical pain in abdomen जैसे ही word आया, it means that your patient is having hidden menstruation. That means there is cryptomenorrhea. Cryptomenorrhea, right? Cryptomenorrhea means hidden menstruation. So the patient is menstruating properly, but the menstrual blood is unable to come out. Why does this happen? The most common reason for this is imperforate hymen, right? Further, your question is going to say that uterus is present. Rather than just saying uterus is present, your question can say uterus is enlarged. Why is it enlarged? Because of blood. That is because of hematometra, right? Your question will say, देखो, in cryptomenorrhea, patient normally menstruate कर रही है, right? LH, FSH levels are absolutely normal. Breast is absolutely normal. Pubic hair and axillary hair are absolutely normal. One more thing with which a patient of cryptomenorrhea can come to you is she can come to you with complaint of urinary retention. Why? Because there is blood inside the vagina, there is blood inside the uterus. Both of them, when there is blood inside the vagina, it can press the urethra. So urethra press हो जाएगा जिसकी वजह से there can be urinary retention. Now, as I told you, the most common cause of cryptomenorrhea is imperforate hymen. How do you come to know that they are talking about imperforate hymen? The hint in the question will be that they are going to say that her hymen is tensed and bulging. Her hymen is tensed and bulging. Then they can say that there is a bluish hymen. Blue colored hymen is because of the collected blood, right? Other causes of cryptomenorrhea are transverse vaginal septum. In transverse vaginal septum, you will never have a bluish hymen. You will never have a tensed bulging hymen. Okay? So look at the question which is asked, and these questions are asked so many times in your papers as well. A young girl who has not attained menarche complains of cyclical pain in abdomen. As I told you, the moment they say cyclical pain in abdomen, it means they are talking about cryptomenorrhea. On examination, her breast development was normal. Local examination has been shown in the image. What are you saying? You are seeing over here that there is tensed bulging hymen. There is a tensed bulging hymen. As I told you, whenever you get a tensed bulging hymen, collected blood will appear blue in color, right? Then, this is imperforate hymen. What is the management of imperforate hymen? Management of imperforate hymen, many times they ask you, and that is you have to give a cruciate incision on the hymen. You have to give a cruciate incision on the hymen. Clear to all of you? Yes? Okay. Now they have started showing you images of hymen also. This is what are you saying, beta? Investigation कोई नहीं करना. हाँ, if you are a NEET PG student and they ask you that on clinical examination how to differentiate between imperforate hymen and transverse vaginal septum, then please remember in imperforate hymen cough impulse is present, in transverse vaginal septum cough impulse is not present. Number 2, you have to remember that if they ask you what is the investigation of choice to differentiate between them, normally you can differentiate between them clinically, but if you have to answer an investigation of choice, then that is MRI, right? That is for NEET PG, not required for FMGs. Now they show you the hymen and they ask you the types of hymen. So in the types of hymen, this is how a normal hymen appears to you, right? This is imperforate hymen. As you can see, there is no opening. This is imperforate hymen. Over here, you are getting a septa in between the hymen. So this is a septate hymen, very, very important. Then they show you the sieve-like hymen, channi ki tarah ka hymen. So sieve-like hymen, that is cribriform hymen, right? Clear to all of you? So this is the images which they show. Coming to question number 2. Now, if they say that there is a female who has come to you with primary amenorrhea and with uterus present. Now, absent breast and pubic hair. This is how the question is going to be, that primary amenorrhea, uterus present, absent breast and pubic hair. Remember, ये जो था ना क्रिप्टोमेनोरिया, इसमें यूट्रस प्रेजेंट था, ब्रेस्ट प्रेजेंट था, प्यूबिक हेयर प्रेजेंट था. Right now they are saying that there is primary amenorrhea जहां पे यूट्रस प्रेजेंट है but breast and pubic hair are not present. Now in this case you have to see, because there can be multiple conditions. One condition, if they say LH and FSH are decreased. Now the moment they say LH and FSH decreased, that means they are talking about Kallmann syndrome. LH FSH decreased. Okay, here I am writing LH FSH decreased means they are talking about Kallmann syndrome. ठीक? So when your question says that breast development absent, pubic hair absent, LH FSH levels less. LH FSH levels less का क्या मतलब है कि हाइपोथैलेमस में प्रॉब्लम है या पिट्यूटरी में प्रॉब्लम है. एंड हाइपोथैलेमस की which problem can lead to primary amenorrhea? Kallmann syndrome. What do you understand by Kallmann syndrome? Kallmann syndrome means that there is hypothalamic failure. Now the question is going to say that height of the patient is normal and an additional feature which is going to be present will be anosmia. Malika, don't say that tall height. It's not tall height, it's normal height, right? Why we are stressing on normal height? Because Turner's syndrome mein height is short. That is why yahan pe we stress that there is normal height. It's not tall height. ठीक है? And there will be anosmia, that is inability to smell. So whenever you are getting a scenario like this, primary amenorrhea, uterus present, breast absent, LH FSH decreased, right? That height of the patient normal, that means they are talking about Kallmann syndrome. As I told you, देखो पूरी gyne में ना, it's very easy to talk about management. Why? Because whatever is deficient you have to give that. जो कम है वो दे दो. Kallmann syndrome में क्या कम है? GnRH कम है. So हमें GnRH देना है. कैसे देना है? In pulsatile manner. So pulsatile GnRH, right? Now Kallmann syndrome के बाद, now suppose they say the same question कि primary amenorrhea है, uterus present है, breast absent है, pubic hair absent है. But now they are saying LH FSH increased है. Please remember बच्चों, whenever LH FSH is increased and estrogen is decreased, it is called as hypergonadotropic hypogonadism. हाइपरगोनाडोट्रोपिक हाइपोगोनाडिज्म. एंड इसका मतलब ही ये होता है कि प्रॉब्लम कहां पर है? प्रॉब्लम इज इन ओवरी. राइट? जब भी प्रॉब्लम हाइपोथैलेमस या पिट्यूटरी की होगी, whenever the problem is in hypothalamus or the problem is in pituitary, LH FSH levels will be low, and that is called as hypogonadotropic hypogonadism. Whenever problem is in ovary, understand, estrogen कम होगा. Because estrogen कम होगा, negative feedback on LH and FSH will be gone, so LH and FSH would be high. So whenever your question is saying estrogen कम है, LH FSH high है, right? Now you are going to say कि मैम क्वेश्चन ने तो बताया ही नहीं कि ईस्ट्रोजन कम है. क्वेश्चन ने डेफिनेटली बताया बेटा ईस्ट्रोजन कम है. क्यों? बिकॉज दे आर सेइंग एब्सेंट ब्रेस्ट. राइट? द मोमेंट दे से एब्सेंट ब्रेस्ट, आई टोल्ड यू, इट मीन्स दे आर सेइंग ईस्ट्रोजन कम है. Right? So whenever LH, FSH, estrogen, all of them are decreased, the problem is hypothalamus pituitary. Whenever LH, FSH high, estrogen decreased, problem is in ovary. Right? Now, in ovary, the problem could be gonadal dysgenesis. What can be the problem? Gonadal dysgenesis. Gonadal dysgenesis can be of two types, Turner syndrome, Swyer syndrome. अगर क्वेश्चन कहता है short stature, that means it is Turner syndrome. अगर क्वेश्चन कहता है normal stature, that means Swyer's syndrome. Turner syndrome का karyotype is 45XO. Swyer's syndrome is 46XY. 46XY. Right? Okay. Now, so whenever, as I told you, whenever your question says that LH, FSH levels are high, estrogen less, uterus present, right? And short stature. Short stature means Turner's syndrome. Karyotype 45XO. Because karyotype is 45XO, that means both X chromosomes are not present. दोनों X chromosomes चाहिए होते हैं proper development of ovary के लिए. In Turner syndrome, because both X chromosomes are not present, that is why the ovaries are not well developed, and that is what is called as streak ovaries. Remember, streak ovaries should not be removed. इसके अलावा, in these patients you are going to get additional findings of Turner syndrome. What are additional findings of Turner syndrome? In pathology you have read webbing of neck, low posterior hairline, shield shaped chest, heart problems, right? Then diabetes, Hashimoto's thyroiditis. Aditya, streak ovaries का मतलब ovaries are not developed properly. जब भी ओवरी को प्रॉपर्ली डेवलप करना होता है, बोथ एक्स क्रोमोसोम्स आर रिक्वायर्ड फॉर प्रॉपर डेवलपमेंट ऑफ ओवरी. In Turner syndrome, because only one X chromosome is present, so ovaries are not well developed, and that is streak ovary. That is why estrogen levels are decreased, and that is why breast development is absent. Because ovaries are not developed, that is why androgen levels are decreased, and that is why pubic hair is not developed. Is that clear to all of you? Yes? Then, same question agar aaye and they say that there is a female who has come to you with primary amenorrhea, uterus present. अब यूट्रस प्रेजेंट है तो क्रिप्टोमेनोरिया भी हो सकता है, यूट्रस प्रेजेंट है तो कैलमन सिंड्रोम भी हो सकता है, यूट्रस प्रेजेंट है तो टर्नर्स एंड स्वायर्स भी हो सकता है. Now your question is saying breast development absent. जैसे ही question कहता है breast development absent, that means cryptomenorrhea gone. Now I am thinking about Kalman. Now I am thinking about Turners. I am thinking about Swyers. ठीक है? Further your question says LH, FSH levels हाई। जैसे ही क्वेश्चन LH-FSH हाई कहता है, आई एम थिंकिंग ओनली अबाउट ओवेरियन प्रॉब्लम्स विच कुड बी टर्नर, विच कुड बी स्वायर्स। एंड फिर क्वेश्चन ने कहा नॉर्मल स्टेचर, नॉर्मल स्टेचर कहा तो टर्नर्स आउट एंड स्वायर्स इन। In Swyer syndrome, karyotype is 46XY. As I told you, जब भी question में male होगा, any male who's coming to you with primary amenorrhea, your question will always say that there is bilateral inguinal hernia. हमेशा question में bilateral excuse me, bilateral inguinal hernia दिया होगा। तो चाहे शॉर्ट स्टेचर से पता लगे कि टर्नर्स है, चाहे बायलेटरल इंग्वाइनल हर्निया से पता लगेगा कि स्वायर्स है। इज दैट क्लियर टू ऑल ऑफ यू? शॉर्ट स्टेचर होगा तो टर्नर्स है, बायलेटरल इंग्वाइनल हर्निया होगा तो स्वायर्स है, नॉर्मल स्टेचर होगा तो स्वायर्स है। क्लियर टू ऑल ऑफ यू? आर यू ऑल अंडरस्टैंडिंग? देन in this case, this bilateral inguinal hernia, they are actually undescended testes. And undescended testes are pre-malignant. They are pre-malignant, right? They can undergo malignancy. That is why you have to do gonadectomy. Right? You have to do gonadectomy. So जब भी Swyer syndrome की patient आएगी, I have to remove those testes. Clear? Yes? So I have to do a gonadectomy. Any confusions? No? Next very important question. SRY gene is located on. Where is SRY gene located? It is located on short arm of Y chromosome. Which end? Distal end. Distal end of short arm of Y chromosome. ठीक है? So I am quickly recapping this for you. Patient comes to you with primary amenorrhea, uterus present. Uterus present है, think of only 4 things. Cryptomenorrhea, Kallmann syndrome, Turner syndrome, Swyer syndrome, right? क्रिप्टोमेनोरिया की पेशेंट में हमेशा दिया होगा साइक्लिकल पेन इन एब्डोमेन। क्रिप्टोमेनोरिया की पेशेंट में ब्रेस्ट डेवलपमेंट नॉर्मल होगा, प्यूबिक हेयर नॉर्मल होगा, LH-FSH नॉर्मल होगा। कैल्मन सिंड्रोम की पेशेंट में दिया होगा LH-FSH डिक्रीज्ड। कैल्मन सिंड्रोम की पेशेंट में दिया होगा एनऑस्मिया एंड कैल्मन सिंड्रोम की पेशेंट में दिया होगा हाइट ऑफ द पेशेंट नॉर्मल, राइट? क्योंकि LH-FSH डिक्रीज्ड है, सो ब्रेस्ट डेवलपमेंट वुड बी एब्सेंट, राइट? Then comes Swyer and Turners. Swyer and Turners में भी breast development absent होगा, but LH-FSH levels would be high. Turner syndrome की patient में they will give you short stature. The moment they say short stature, you come to know it is Turner syndrome. Swyer syndrome की patient में they are always going to say that we are एक तो तुम लोग इतने कमेंट लिखते हो ना कि माई माइंड गेट्स डाइवर्टेड। व्हाट वाज आई टेलिंग यू? स्वायर सिंड्रोम की पेशेंट में दे विल ऑलवेज से दैट देयर इज बायलेटरल इंग्वाइनल हर्निया, राइट? सो व्हेनेवर दे से बायलेटरल इंग्वाइनल हर्निया, देन यू हैव टू take it as XY karyotype and that is Swyer. Okay, अब मेडिको क्या बोल रहे हो? मैम Y क्रोमोसोम याद किया था, शॉर्ट आर्म और ऐड कर दिया आपने। हाँ, तो शॉर्ट आर्म ऑफ Y क्रोमोसोम, उसमें क्या ऐड कर दिया ये तो सबको पता है, ठीक है? याद रखना, शॉर्ट आर्म ऑफ Y क्रोमोसोम। अब आता है प्राइमरी एमेनोरिया विद यूट्रस एब्सेंट। प्राइमरी एमेनोरिया विद यूट्रस एब्सेंट बहुत सिंपल है, either it is Mullerian agenesis or androgen insensitivity syndrome, ठीक है? Androgen insensitivity syndrome में again what are they going to say? Androgen insensitivity syndrome में again they are going to say that bilateral inguinal hernia is present. हमेशा बोलेंगे bilateral inguinal hernia प्रेजेंट है, राइट। मुलेरियन एजेनेसिस में क्या बोलेंगे? मुलेरियन एजेनेसिस में they will always say that uterus is absent, breast and pubic hair both are well developed. Mullerian agenesis का मतलब क्या है? That means both Mullerian ducts are absent. Both Mullerian ducts absent means we are dealing with Mullerian agenesis. Now when both Mullerian ducts are absent, ovaries are normal. Why are ovaries normal? Because ovaries develop from genital ridge. Right, so ovary is normal. Because ovary is normal, LH levels, FSH levels and estrogen levels, all of them are normal. So breast development भी normal है, pubic hair भी normal है. So if you get a question which says uterus absent, breast normal, pubic hair normal, दोनों normal, LH, FSH, estrogen normal, that means you are dealing with Mullerian agenesis. राइट, सब कुछ नॉर्मल है. प्रॉब्लम यह है कि मुलेरियन डक्ट ही नहीं है. मुलेरियन डक्ट नहीं है तो यूट्रस नहीं है. बाकी एलएच भी नॉर्मल है, एफएसएच भी नॉर्मल है, ब्रेस्ट भी नॉर्मल है, प्यूबिक हेयर भी नॉर्मल है. इन सम केसेस they can say a small blind vagina present. So इसमें कंफ्यूज नहीं होना है. All of you know कि upper part of vagina develops from Mullerian duct. तो obviously small blind vagina present होगी. Then your question can say renal anomalies are present. So Mullerian duct is also responsible for formation of some parts of renal system. So renal anomalies can also be present, right? Now, if your question says breast तो well developed है, but pubic hair scanty है, so your question will say breast corresponds to Tanner stage 4 or 5 and pubic hair corresponds to Tanner stage 1 or 2. Then it means they are talking about androgen insensitivity syndrome. In androgen insensitivity syndrome, the karyotype is 46XY, right? Additional features which they are going to tell you are there is bilateral inguinal hernia, and sometimes in these patients also a small blind vagina can be seen. As I told you, whenever your question says primary amenorrhea with bilateral inguinal hernia, you have to think about 46XY. 46XY में uterus present means Swyer's syndrome. Uterus absent means androgen insensitivity syndrome. ठीक है? Now let us see a few questions which have been asked in your exam. So ये देखो. A 16-year-old female visits Gyne OPD with complaint of cyclical pain in abdomen. जैसे ही उन्होंने बोला cyclical pain in abdomen, what do you think about? You have to think about cryptomenorrhea. And cryptomenorrhea में most common cause कौन सा होता है? Imperforate hymen. Her general examination shows normal breast development, normal pubic hair development. Local examination shows bluish bulging hymen. Per rectal examination में uterus is palpable. Most appropriate management. What is the management of imperforate hymen? What is the management? Cruciate incision. हो गया question? Done. Next PYQ. A mother brings her 18 years old child to Gyne OPD who has not attained menarche, normal LH-FSH. अब your question is saying normal LH-FSH, normal breast development and pubic hair development. Small blind vagina, absent uterus. कितना तो आसान कर दिया. Karyotype 46XX. Absent uterus 46XX का मतलब है Mullerian agenesis. As I told you, Mullerian agenesis में LH, FSH, everything would be normal. In case of Mullerian agenesis, breast development will also be normal, pubic hair will be normal. In androgen insensitivity syndrome, breast is well developed, pubic hair is not well developed. ठीक? So answer is Mullerian agenesis. I hope now you people have become slightly confident in primary amenorrhea. सारे क्वेश्चंस रिलेटेड टू प्राइमरी एमेनोरिया आंसर हो जाएंगे? जल्दी से राइट यस और नो। अब इससे जल्दी और इससे बेटर आई कुडंट हैव टोल्ड यू। Then I'm going to go to secondary amenorrhea. Chalo, let's talk about secondary amenorrhea. Now, secondary amenorrhea may be you have to think about problems related to hypothalamus, problems related to pituitary, problems related to ovary, and problems related to uterus. Secondary amenorrhea ka na, first I would like to tell you the causes. Please remember, most common cause secondary amenorrhea mein likho. Most common cause of secondary amenorrhea is pregnancy, right? Then the other causes में causes related to hypothalamus. Causes related to hypothalamus are excessive exercise, right? Excessive dieting, that is anorexia, excessive eating, that is bulimia. Then causes related to pituitary. Causes related to pituitary दो होते हैं. One is Sheehan syndrome and the other one is prolactinoma. Then causes related to ovary. Causes related to ovary भी दो हैं. PCOS and premature menopause. Then cause related to uterus. Cause related to uterus is Asherman syndrome. अब from our physiology knowledge and जो मैंने अभी तक बताया, I told you, जब भी problem hypothalamus या pituitary की होगी, LH, FSH, estrogen, all these are going to be decreased. जब भी problem ovary की होगी, LH, FSH will be increased, estrogen will be decreased. जब भी प्रॉब्लम यूट्रस की होगी, LH नॉर्मल होगा, FSH नॉर्मल होगा, estrogen नॉर्मल होगा. PCOS is a problem of ovary, but in case of PCOS, please remember, PCOS के patients में FSH is normal, LH is high, right? So that is what you have to remember about PCOS. So all this is something which we've understood because we know कि hypothalamus, pituitary and ovary, what kind of hormones they are releasing and what kind of negative feedbacks are there, right? Now based on this, let's quickly talk about secondary amenorrhea. In secondary amenorrhea, the most common cause is pregnancy. That is why the first test which you have to do whenever there is a patient coming to you with secondary amenorrhea, the first test which you have to do is urine pregnancy test. In case of pregnancy, placenta is forming estrogen, so estrogen is increased. Placenta is forming progesterone, so progesterone is increased. Both estrogen and progesterone have a negative feedback on LH and FSH, so LH and FSH are decreased. Your question will tell you some of the symptoms of pregnancy and UPT would be positive. So that is about pregnancy. Then let's talk about premature menopause. Premature menopause के केस में क्या है? Premature menopause, it is also called as primary ovarian insufficiency, POI. When do you call it as premature menopause? When menopause is happening at less than 40 years. Now there are no more follicles in the ovary. Because there are no more follicles, estrogen decreased, progesterone decreased, LH, FSH increased. But UPT is positive. UPT is negative. Your question will say UPT negative, LH, FSH increased. जब भी question कहे FSH increased and secondary amenorrhea, this is the only condition जहां पे FSH हाई होगा and patient will have secondary amenorrhea. Whenever your question is saying FSH levels high, that means the problem is in ovary, right? And that means the problem is premature menopause. ठीक है? Then comes PCOS. PCOS के patients में the problem is anovulation, right? In a patient of PCOS, estrogen level can be normal or it could be increased. Progesterone levels are decreased. FSH levels are normal. LH levels are high. Please remember normally. Normally LH is to FSH is 1:1. In a patient of PCOS, LH is to FSH becomes 2:1 or 3:1. Right? PCOS के patient में they are also going to say that there was hirsutism, or they may talk about irregular cycles. They may talk about obesity. All these things can be present in your question, right? Then coming to prolactinoma. Prolactinoma is a prolactin secreting pituitary tumor. As I told you, prolactin has a negative feedback on GnRH. So whenever there is going to be a prolactinoma, LH and FSH levels will be decreased. Problem hypothalamus की होगी या pituitary की होगी तो always LH FSH would be decreased. Problem ovary की होगी, that is premature menopause, तो FSH would be increased, right? Now, because LH and FSH are decreased, I have to think about problems related to hypothalamus and pituitary. What are the hints in the question which will tell me that they are talking about prolactinoma? Please remember, because prolactinoma is a prolactin secreting pituitary tumor, that is why due to pressure symptoms, pituitary का tumor है, question में दिया होगा patient has headache, right? Because pituitary is very near to optic chiasma, तो क्वेश्चन में दिया होगा विजुअल डिस्टर्बेंसेस. बिकॉज इट इज सिक्रीटिंग प्रोलैक्टिन, सो क्वेश्चन में दिया होगा गैलेक्टोरिया. ठीक है, जब भी क्वेश्चन में दिया हो सेकेंडरी एमेनोरिया विद हेडेक, विजुअल डिस्टर्बेंसेस, गैलेक्टोरिया, दैट मीन्स दे आर टॉकिंग अबाउट प्रोलैक्टिनोमा. Now, what is the most common symptom of prolactinoma? अगर ये question आएगा, that what is the most common symptom of prolactinoma? Please do not say galactoria. Galactoria is not the most common symptom of prolactinoma. Most common symptom of prolactinoma is secondary amenorrhea. Secondary amenorrhea. That's the most common symptom of prolactinoma, right? Then when I am going to do MRI in a patient of prolactinoma, I am going to get a space occupying lesion. Space occupying lesion, right? Coming to Sheehan syndrome. In Sheehan syndrome, what is there? There is necrosis of the anterior pituitary gland due to PPH. Right? Again, because the problem is in pituitary, so LH, FSH levels will be decreased. How am I going to come to a conclusion that there is Sheehan syndrome? Because your question is going to say that your patient was unable to feed the baby. Patient ने deliver किया, but she was unable to feed the baby, right? Then I come to know that there was Sheehan syndrome. When I am going to do MRI, I am going to get empty sella turcica. Empty sella turcica. Right? Inability to breastfeed the baby. That is the complaint with which a patient of Sheehan syndrome is going to come to you. Right? Then comes Asherman syndrome. In Asherman syndrome, you are getting a lot of additions inside the uterus. There are intrauterine synechia or intrauterine additions. बिकॉज इसमें हाइपोथैलेमस नॉर्मल है, पिट्यूटरी नॉर्मल है, ओवरी नॉर्मल है, so LH, FSH, estrogen, everything will be normal. Hint in the question given to you would be, they are going to say that there is history of previous curettage, right? Or your question can say estrogen plus progesterone challenge test negative. Whenever your question says estrogen and progesterone challenge test negative, it means they are talking about Asherman syndrome, right? This is how you differentiate between progesterone test negative, estrogen and progesterone challenge test negative. Now come to these questions. These are, which of the following is not a cause of secondary amenorrhea? Is Sheehan syndrome a cause of secondary amenorrhea? Yes. Asherman, yes. Turner's, no. Kalman's, no. Right? Then they asked, match the condition with appropriate hormone levels. How are you going to match it with hormone levels? Asherman syndrome में क्या मिलता है? LH, FSH and estrogen, everything normal. शीहान में क्या मिलेगा? शीहान पिट्यूटरी की प्रॉब्लम है, सो LH डिक्रीज्ड, FSH डिक्रीज्ड, ईस्ट्रोजन डिक्रीज्ड. देन PCOS में क्या मिलता है? PCOS में FSH नॉर्मल होता है, राइट? LH हाई होता है एंड ईस्ट्रोजन is also normal or estrogen can be high. So let us see, premature ovarian failure में क्या मिलेगा? Premature ovarian failure में LH, FSH both would be high. So जहां पे LH, FSH both high है, वहां पे I am marking it as POI. जहां पे only LH high है and FSH को उन्होंने decreased लिखा है, normal होता है, right? Estrogen भी normal होता है, instead of normal they have written it as decreased, but that is the only option which is remaining, so I am going to mark that as the answer. Right? Rule out करके आंसर्स को निकालो. Clear to all of you? Yes? Okay. Now look at this question. A 24-year-old female, this is again your PYQ. A 24-year-old female attends Gyne OPD with secondary amenorrhea. She has history of previous DNC. So she has history of DNC. Her FSH levels are 6 international units. 6 international units का क्या मतलब है? Normally कितना होता है FSH? 1 to 10. 6 का मतलब absolutely normal. So absolutely normal levels of FSH and she has previous history of DNC. क्या हो गया? Asherman syndrome. Clear to all of you? Yes? Any confusions? No? Chalo. Coming to a few important PYQs, single liners which they ask you. What is the best method of sex determination? Best method for sex determination is karyotyping, right? If Y chromosome is present, then we say that we are dealing with male. If Y chromosome absent, then the female, then the sex of the patient is female, right? What is the most commonly used method? Most commonly used method is by looking at external genitalia. Right? Then, what is bar bodies? Bar bodies is another method of sex determination where the number of X chromosomes minus 1 is equal to the number of bar body. Now, over here, I want to tell you, karyotyping is the best method. So, according to karyotyping, if Y chromosome is present, we call them as males. If Y chromosome absent, females. So, if I ask you, according to karyotype, Turner syndrome babies are male babies or female babies? Turner syndrome is 45XO. That means Y chromosome absent. Y chromosome absent hai, so they will be females. Very good. अब बताओ, Klinefelter syndrome. Klinefelter syndrome 47XXY, ये मेल हुए कि फीमेल हुए? Klinefelter syndrome males या females? 47XXY. Priyanshu, very good. तो Klinefelter syndrome babies will be male babies. Why? Because Y chromosome is present, right? अब नाउ लेट अस टॉक अबाउट बार बॉडीज. बार बॉडीज में एक नॉर्मल मेल में who is 46XY, what will be the number of bar bodies? 0, right? एक नॉर्मल फीमेल में क्या होगा? नॉर्मल फीमेल हु इज 46XX, उसमें क्या होगा? 1. अभी आई टोल्ड यू कि टर्नर सिंड्रोम को हम फीमेल मानते हैं, लेकिन टर्नर सिंड्रोम में हाउ मेनी बार बॉडीज एम आई गोइंग टू गेट? 0. That is the problem with bar body. Bar body say you cannot come to know the sex because Turner syndrome we take them as females, but bar body is telling me that they are males because bar body is 0. Similarly, Klinefelter's syndrome. Klinefelter's syndrome ko we take them as males, right? They are 47XXY. But the number of bar body will be 1. So bar body gives you false results. Same question has been asked in your exam. This is your PYQ. In which of the following condition there will be false positive bar body? False positive का मतलब that they are actually males but they are having a positive bar body. In which condition are you going to get a false positive bar body? You are going to get it in Klinefelter's syndrome. Are you understanding? False positive. False positive का मतलब कि गलत है उसका पॉजिटिव रिजल्ट. पॉजिटिव आना चाहिए था फीमेल में, बट एक मेल में पॉजिटिव आ रहा है. दैट इज फॉल्स पॉजिटिव, राइट? ओके. नाउ सिमिलरली इफ दे आस्क यू फॉल्स नेगेटिव, फॉल्स नेगेटिव रिजल्ट किस में आता है? फॉल्स नेगेटिव रिजल्ट आएगा टर्नर्स में. टर्नर्स में एक्चुअली आई शुड हैव बीन गेटिंग 1 bar body, but I get a negative result and this negative result is a false negative result. Clear to all of you? Then comes homologous structures. Homologous structures are those structures which develop from the same embryological origin. Right? So if embryological structure is genitals, ekdam se this has gone out of my mind. Just hold on. Genital swelling, genital folds and penis and clitoris develop from, जल्दी बताओ, it has slipped my mind. I am not getting that term in my mind. Penis and clitoris, they develop from, you will have to help me. I've just forgotten that term. It slipped out of my mind. Tubercle. Yes, thank you so much. Tubercle. Ridge नहीं है बेटा. Ridge से ovary and testes develop. Genital tubercle. Thank you so much, Shubhank. Thank you. So genital tubercle. Genital ridge नहीं है बेटा. Genital ridge से ovary and testes develop. It's genital tubercle. So if the embryological structure is genital tubercle and male's genital tubercle is going to form penis, in females it is going to form clitoris. Right? So they are homologous organs because both penis and clitoris are developing from genital tubercle. Then genital swellings. Genital swelling in males it is going to form scrotum. In females it is going to form labia majora. Right? Then genital folds. Genital folds in males is going to form penile urethra. In females, labia minora. Right? Now, these are homologous structures. In glands, I want you to remember, in males, prostate gland is homologous to which gland in females? Skin glands या paraurethral glands. right? Then Cowper's gland. Cowper's gland is also called as bulbourethral gland. Bulbourethral gland in males is homologous to Bartholin glands in females. Clear? So these are homologous structures which are present in males and females. Next question. What is the most common cause of ambiguous genitalia? What is ambiguous genitalia? When by looking at the genitalia you cannot decide the sex of the baby. So what is the most common cause of ambiguous genitalia in a female, if they ask you this question? Or if they ask you what is the most common cause of female pseudohermaphroditism? Whether they say female pseudohermaphroditism or whether they ask you most common cause of ambiguous genitalia in females, answer Lalit, very good. Answer is congenital adrenal hyperplasia. Most common enzyme deficiency leading to congenital adrenal hyperplasia, 21 alpha hydroxylase enzyme deficiency. Right, so most common enzyme deficiency leading to congenital adrenal hyperplasia is 21 alpha hydroxylase. What is the most common cause of ambiguous genitalia in males? It is partial androgen insensitivity syndrome. अगर ऑप्शंस में पार्शियल एंड्रोजन इनसेंसिटिविटी सिंड्रोम लिखा है, दैट्स द बेस्ट आंसर. पार्शियल वर्ड नहीं दिया है, देन यू आर गोइंग टू मार्क द आंसर एज androgen insensitivity syndrome. But if word partial is given, then yes, you have to mark it as partial androgen insensitivity syndrome, right? Now, all of you know that in intrauterine life in males and females, we have both the pairs of duct, Wolffian duct and Mullerian duct. In males, what does Wolffian duct do? Wolffian duct, it leads to the formation of male internal genital organs. And what are male internal genital organs? SEED. Seminal vesicles, ejaculatory duct, epididymis and vas deferens. Seminal vesicles, epididymis, ejaculatory duct and vas deferens. Mullerian duct regresses in males, and when Mullerian duct regresses in males, it is going to leave certain remnants. What are the remnants of Mullerian duct in males? Very, very important question. Number 1, prostatic utricle. Prostatic utricle. And number 2 is appendix of testes. Appendix of testes. The other name for appendix of testes is hydatid of Morgagni. Hydatid of Morgagni. Right? So this is how the ducts are going to behave in males. In contrast to this, in females, it is the Wolffian duct which is going to regress. When Wolffian duct is going to regress, it is going to form remnants. And what remnants it is going to form? It is going to form epoophoron, paraophoron and Gartner's duct. Gartner's duct. It is Mullerian duct which is going to form female internal genital organs. What female internal genital organs it is going to form? It will form fallopian tube, it will form uterus, cervix and upper vagina. Please remember, from where do ovary develop? Ovary develop from genital ridge. Ovary has nothing to do with Mullerian duct, and that is why in Mullerian agenesis, when both Mullerian ducts are absent, still ovaries are normal, right? From where does lower vagina develop? Lower vagina develops from sinovaginal bulb. Sinovaginal bulb, it comes from urogenital sinus. Urogenital sinus, right? Now, next and a very, very important question which you get is on Bartholin cyst. This over here is a Bartholin cyst. Whenever you see a cyst which is present between labia majora and labia minora, please remember it has to be a Bartholin cyst, right? Anytime if you are getting a cyst between majora and minora, it has to be Bartholin cyst and nothing else, right? I just want all of you to remember that management of Bartholin cyst, if the cyst is asymptomatic and it is less than 3 centimeters, then no management. Conservatively ही manage हो जाएगी. If it is more than equal to 3 centimeters, incision and drainage. If it is a Bartholin abscess, then again incision and drainage. If it is recurrent Bartholin cyst, then in that case you have to go for मार्सुपिलाइजेशन. बहुत सारे बच्चे मैनेजमेंट ऑफ बार्थोलिन सिस्ट को कह रहे हैं मार्सुपिलाइजेशन. द आंसर हैज चेंज्ड. बार्थोलिन सिस्ट का मैनेजमेंट नाउ इज इंसिशन एंड ड्रेनेज. रिकरेंट बार्थोलिन सिस्ट का मार्सुपिलाइजेशन. क्लियर टू ऑल ऑफ यू? Yes? Understood? What is the other name for Bartholin gland? The other name for Bartholin gland is greater vestibular gland. Right? That's the other name for Bartholin gland. So this is what you had to remember in the female external genitalia and internal genitalia development. Coming to syndromes in gyne. I think your orthopedic session is also scheduled. Is it for 5 o'clock or 4 o'clock? If it is for 5 o'clock, I'll take a 15 minutes break. Just let me ask. Hold on, just let me check. When is your next session planned? 5 o'clock. So your next session is planned at 5 o'clock. Yeah, it's at 5 o'clock. So in that case, can we take a 10 minutes break? I want to have some water, right? So you also have some water, tea, and we continue because अभी थोड़ा चलेगा ये लंबा. अभी we are on page number 20. अभी हम आधे session पे पहुंचे हैं, right? Not even half. I have 48 pages to tell you, and this is just now page number 20. So let's take a 10 minutes break and then we meet again. This is 3:30 and I am going to see you at 3:45. Yes, let's meet at 3:45 and we continue the session at 3:45.